Today, we are having the 85 years old male with hypertension and presenting to us with left lower limb rest ischemia pain, which is rated as the Rutherford force. And he is a smoker, and after being hospitalized, he is taking aspirin and statin. For physical examination, he has muscle atrophy for both lower limbs, and we cannot feel the pulse, and the foot is quite pale. For the ABI, the left pope is 0.5, and both AT and PT are 0. Next, please. And these are his CTA before operation. We can see the disease is mainly focused on the left external iliac artery, right? And also there's some disease on the SFA. Um, but the collaterals are quite good. And if we zoom in, we can see a lot of calcifications in the iliac artery, and also we can see some calcification for the SFA. And we will use 6 and 8F long sheets for the vessel access and crossover. We have a bunch of glide wires, V18, Command 14 glide wire, stiff glide wire, and we are also prepared for using balloon for the PTA, and for the iliac artery. For our experience, there's mostly are stenosis and also thrombosis, right? So for the safety course and also for iliac artery, if we're using the BMS, if we post the dilation too hard, the artery probably will break and perforation. So for the safety case and also for the thrombosis, like we prefer the Viabahn for the treatment of the iliac artery. You can see a lot of calcification for this gentleman. Of course, considering the smoking history, considering the age, which is not very surprising, but also bringing us a lot of trouble for treating this kind of patients, right? This is the close look for the disease for external iliac artery. This is we are using glide wire to passing the disease, and you can see here there's some resistance here, but for most of the disease we are crossing it pretty good and easy. So we are considering it might be some a short segment of stenosis or occlusion, and after that there's generated some thrombosis. For right now, we are having a supercall wire in the vessel for the support, and well, next step we are going to change a 8F sheath for the Viabahn through. And next, after we successfully changing the sheaths for 8 French, we are now measuring the diameters of the blood vessel. But there's a different methods for measuring the blood vessel for choosing the right size of the stenting. Of course, you can do it for the CTA, which is more like us, right? We measure the blood vessel before before the operation, so we can have a fully prepared operation going on. But you have to measure the exercise in the during the operation. So here we are using the a balloon with a marker from BD company.
Ultraverse.
Ultraverse, yeah,
Ultraverse.
Ultraverse,
We can see that.
which have markers for the on the catheter on the balloon, so we can actually measuring, and we will go push the balloon a little bit, 44, and so what's the diameter choosing of this case? So the blood vessel diameter is 8 millimeter around, right? So we are choosing a Viabahn for a little bit smaller. So in this case, we can overlap a little bit for the internal iliac artery, and so even though it doesn't matter, so because the size is a little bit smaller, so the blood can still flow into the iliac, internal iliac artery, but we can also covering the disease and opening the lumen, using the sheath to protect the Viabahn, right? So make sure the Viabahn will not be wore off before you put it to the right place. All right. Okay, make sure again for the proximal landing zone.
Okay.
All right. A little bit more overlapping, but it doesn't matter because we are choosing smaller size of the Viabahn. So we can still, probably will still see some blood flow into the internal iliac artery. So for this case, saving the internal iliac artery is actually the secondary goal for this one, right? So the primary goal is making sure the opening of the blood vessel to make sure to relieve the symptoms.
It's okay.
All right. Slowly deploy the Viabahn.
Okay. Slowly. Slowly. And a half. Okay.
Oh, there we go.
Okay.
So we can see the opening of the
No,
Viabahn.
no. Okay. Stop.
So we deployed half of the Viabahn, and we gave a little bit of dye to see it, to make sure that the position. And Dr.
Slowly,
Sun
and
is
then we.
playing to when you're deploying the Viabahn, and also you are pushing the Viabahn inside. So you shorten the Viabahn, and you can preserve the internal iliac artery.
Yeah.
So for the road map, you can see the
Okay.
original place for the proximal place, and right
Okay.
now,
Very well.
perfect, perfect,
Perfect.
perfect. Wonderful, wonderful.
Mm,
618
the
balloon for
balloon.
poster dilation.
Yeah. And then you can see the Viabahn,
Mhm.
maybe the nine,
Yeah.
the nine lines, and
And now it's we are shortening it to around 18, right?
yeah.
Mm. So that's a little bit of trick. You can actually push in Viabahn during the deploy.
Eight, eight.
So let's. I think this is final angle.
Yeah.
Maybe perfect. Couldn't be better. So the internal iliac artery is preserved. The disease is covered, and the Viabahn, although we are choosing 100, but by using the little tricks for deploying, we are actually shortening it to the 80 millimeter. So let's see if we have any distal thrombosis occurred.
Yes.
And preserving those collaterals actually is very important. Still looking good. The deep femoral artery is still very, very good. And let's see the Pope. Oh, I think this is a disease for the SFA, right? The severe calcified part. We tried. We actually tried, but it's really hard to open it. If we wanted to successfully open it, I think we'll use the retrograde access to see if we can pass the fibrinosis cap. For the distal SFA, I think it's all right from the collateral, right? Maybe one or two hard cycle, and you can see the dye going through to the SFA after we opening the proximal iliac artery. It might be getting better. And I have a question for you, Dr. Sun. Do you worry about the distal flow out for the Viabahn? Because you can see that the distal part is actually very close to the joint. Are you worrying about that for the further the longer patency rate? So the primary goal is to cover the disease, right? And if it's a little bit of going into the joint area, which is fine. Because you have to make sure the vessel open first.
Someone asked, for this kind of lesion, should we consider the use of plaque modification? because you talk about this debarking for this kind of lesion is kind of risky.
Uh-huh.
Can you talk more about this kind of plaque modification?
Debulking. Okay.
Yeah.
So back to the original question. Why don't you use debulking for the iliac artery, right? So for our center, for the severe calcified disease is quite risky. It's quite risky for the BMS. That's why at first we are choosing the covered stent. That's the first place. The second place is also for the iliac artery is always stenosis, CTO disease, and accompanied by thrombosis. It's always. I don't know the literature reporting the rate, but for our experience, it's always like that. So using covered stent is much safe for the distal thrombosis. The third one is for the debulking method for the iliac artery. It's still the same for the safety first. If you are debulking and the patient is severely calcified, it probably making the perforation, which is very bad for us. You can have to either emergency you can deploy the covered stent, or you have to go in open for the open surgery. And for this kind of age, 85 years old gentleman, you are going open surgery, which is actually killing him, right? So what's the next question?
Okay, I know for this kind of lesion, it's kind of risky to do the deparking.
Mhm.
But what if, if you have to do the plaque modification or deparking, what kind of
Debulking.
device you may try to decrease the risk of perforation?
Actually, if for the safety by using debulking, first you have to pre-evaluate the size of the vessel. So if the patient's vessel is too small, you definitely cannot use the debulking methods. Like Dr. Sun just mentioned, when the glide wire passing that stenosis part, that's definitely the narrow part. So if you are using debulking, avoiding to debulk that part. So if you are doing debulking for that part, CTO part, probably making perforation. So you can do proximal part, you can do it for the distal part, but trying to avoid that stenosis part. So in that case, sometimes you are hard to determine which part is which part. So for the safety, we are just trying to avoid debulking. Do we use debulking for iliac artery before? Yes, I think the answer is yes, definitely. We used that before.
Yeah, the second question, Professor Liu invented a software to do the 3D reconstruction of the coronary arteries. I don't know if you have seen that kind of image or not. Except for the CT angiography, is there any other assessments to evaluate this kind of lesion?
Unfortunately, for our department right now, we only have CTA. And after using CTA for so many years, like 10 years, 15 years,
More than 10 years.
more than 10 years, for using CTA for the pre-operation evaluation, we are actually good at it. We are actually good at it. So CTA is very important. You can see the different characters of the disease, calcification, the low density plaque, the other kind of plaque or dissection, whatever. You can actually see everything. And after that, we will combine with medical history, right?
Yeah, the medical
History is very important.
Yeah.
And there's also some lab parameter like D dimers, and if it's D dimers is increased, significantly increased, so we probably considering about the thrombosis stuff. So it's never just the one single factor to determine what's the strategy next. It's always different things combined together to making decision. So, like you said, the software probably will be good, but right now for us, we are not using it. But if there's a chance, we will use it in later.
And
It'll be
there's
good.
another question, because how about the use of intravascular imaging for those kind of lesion, like AVAS or OCT? Do you have any experience doing this kind of imaging tests?
Using IVAS for the iliac artery. To be honest, we don't have the experience, and we are trying to show you the actual working situation for us in this department for now.
So what do you think of the future of the imaging test, for the peripheral intervention in the future?
you don't have to use IVUS to guide you. And you can still finish the job.
Yeah.
And but for SFA and Pope, it's probably different, right? So using IVUS to decide the AAA. Yeah, I do see some people using IVUS for AAA.
Yeah, you see?
For like infrarenal or junctional, which is pretty complex. You're trying to selection different branches. So they might using that for the aortic. But you are talking about the patency for the iliac artery. So because the patency for iliac artery is actually pretty good, better than the SFA and the Pope.
Yeah.
So no matter if you have IVUS, you just put in a stent in, and it can last for quite a long time. But SFA and the popliteal is quite different. You have to plan it carefully. You have to decide carefully. You have to see it's very accurate and to make your final decision to either doing DCB or using stent, or actually just the debulking is good enough. So I think basically the Dr. Sun's meaning is it's all depend on patency. So for these patients, probably after we put in the Viabahn here, he can last for a really long time, even you don't use the IVUS. But for if we will successfully pass the disease for the SFA, we definitely should use IVUS to see the actual situation in there.
And also, let's get back to these patients because there's still severe stenosis in SFA. So are you going to treat that lesion in the future, or are you just going to follow up the patients and then decide whether or not you are going to treat that lesion?
We are definitely choosing follow-up right now. Because collateral, you can see for the angio later on, the collateral is very good. They're very good. And after you open the proximal iliac artery, you can see the from the collateral, the popliteal and the BTK arteries actually doing good. They are doing good. So based on our experience, if you are opening the proximal arteries, it can definitely relieve the symptoms. Okay. So, but if the patients actually have a Rutherford 5 or 6, which had gangrene or ulcer on the foot, we definitely recommend opening the iliac artery and SFA, because it will help for the healing, you know. But right now, this patient only have rest pain, so we think iliac artery is good enough, and we can cut in the budget. We can cut in the intervention, and we can solve the problem.
All right.
There we go.
Personally, I also have a question about this procedure because if we put a stent, so usually we give the dual antiplatelet therapy for 1 year, and then we may stop the use of clopidogrel and use aspirin for the lifetime. So how about for the peripheral intervention? After the cover stent implanted in these patients, so how long are you going to use the dual antiplatelet therapy? Actually, we are kind of a little bit different for the guidelines compared with cardiology. For the lower limb, we are the current guideline is trying to recommending using single antiplatelet and anticoagulation. So single anticoagulation plus single antiplatelet and statin. For how long? For forever. For lifetime? One antiplatelet therapy plus one anticoagulation for lifetime.
At least 6 months.
At least
6 months.
Okay.
And the aspirin for lifetime.
For lifetime. Yeah.
So what do you think of the use of clopidogrel?
I think there's a higher risk for clopidogrel resistance. So for our department, we're choosing aspirin first. You prefer to use aspirin? Yeah. Okay. Yeah. Choosing the right plan, not one plan for everyone.
Yeah.
That's the first one. The second one is choosing the right instrument for different lesion. So for the iliac, definitely using covered stent is much safer than any other stuff. And debulking have a great risk, and you have to use it with great caution. And other than that, I think we are good, right? Yeah, I think we are good.
All right. Okay. Thank you. You
Thank you
guys
so
Thank
here
you.
much.
Very
deserve a round of applause. Thank you so much for your
Thank
efforts.
you.